Dugan. I'll be helping host today's session alongside our speaker, Dr. Pamela Scarborough. We are so thrilled that y'all can be here today. This series has been wonderful so far, and we're excited to continue it. While we wait for just another moment for everyone else to arrive, quick housekeeping items. Feel free to use the chat at any time to share your questions. I will be keeping an eye on it and we'll jump in when the timing is right to help answer any questions from Pamela. I'll also be dropping the PowerPoint and some resources that pair with today's presentation. This webinar is being recorded, so you'll also get that in the email as well after the session, as Pamela mentioned. So that email will include the recording and all of the handouts for today. You're welcome to share and disseminate that information. It's all public information that we just want everyone to know for wound education. And real quick, if this is your first session with us, I just wanted to share briefly who we are at United Wound Healing. Our company started in 2015, and we had one goal: to make expert wound care more accessible by bringing it directly to our patients. That approach has helped improve comfort, outcomes, and lowering costs for thousands of patients every single year. Today, we partner with over 400 facilities in Washington, Oregon, Idaho, and Utah, and care for more than 15,000 new patients annually. Two of our big initiatives, as you'll see listed here: Open Wound Research. This arm of our company is focused on making wound care data and research open, shareable, and actionable. And our fellowship program, this is the first in the nation dedicated to advanced training in wound care, dermatology, and limb preservation. This is for nurse practitioners and physician associates. So if that is of interest to you or you know anybody, I'll also share links to that and you can learn more about what that process looks like. And with that, I'm going to kick it over to Pamela. Dr. Pamela Scarborough is our Director of Education, and she's also the Director of our fellowship program that I was just talking about. She's nationally recognized as a wound care educator, a founding faculty member of the Wound Certification Prep course, and brings over 40 years of clinical and teaching experience to her work. Pamela, the floor is yours.
Thank you so much, Jacqueline. Good job. Really appreciate that. And Jacqueline may have said something that you picked up on, or maybe you didn't pick up on. She's called our PAs a physician associate. The name has changed nationally from a physician assistant to a physician associate. So in case you didn't know that, a little bit of tidbit of update for today. So the first thing I have to do is I have to do this. I have to read the disclaimer. So this information is provided for informational purposes only. Patient care decisions should be based on relevant clinical guidelines, including current evidence-based literature, which all of this is on current evidence-based literature, state and federal guidelines. If you stay with me, you're going to see F686, F684, F880. You will see the guidelines come in that help to frame your work in long-term care. It's different in other post-acute care settings. The OASIS helps to drive some things related to reimbursement and home health. And when we get to assisted living facilities and post-acute care, their rules are a little bit different. So you need to know the rules for whichever care setting you work in. And with some of you, please put in the chat where you work. Are you long-term care? Are you home health? Are you assisted living? Where is it that you're working? Because most of the content that we have here is related to the post-acute care setting, specifically long-term care. So you want to look at your evidence-based literature, your state and federal guidelines, and your own facility protocols. Do you have protocols on how to do a dressing change, how to do a clean dressing change, for instance, which you need to have protocols for training all of your new nurses who come in and may not have this education yet. So where are your protocols? Decisions from wound management should be based on a holistic review of the patient's condition. I just got a note from one of our team people that there are some people in long-term care who think you do not have to do a skin assessment on admission, and they're pushing back from doing a skin assessment. And they made this up because I'm telling you, everybody, you have to do a skin assessment on admission, or you're going to be truly between a rock and a hard place. So, and that's coming from CMS. And you want to look at the whole patient, the clinical team members. You need to rely on your training and expertise. The only group of medical professionals that I know of currently that get wound prevention and management as part of their curriculum, that is the profession of physical therapy. Nursing isn't getting it. Physicians, physician assistants, nurse practitioners aren't getting it. So if you didn't get it in school, you're going to have to get this information from someplace else. And this is one of those places to get it. It's going to help you with this is education. That education is internalized into knowledge. You don't own it until you make it knowledge. This is just the education part. Unless you internalize it, it doesn't mean anything to spend your time doing this. So you want to rely on your training expertise. And if you didn't get this training, this is a good place to start, as well as all available clinical and other pertinent information about that person's case, about that patient or that resident's case. You want to know everything about that resident, not just what's going on at the skin level, because whatever's happening under the skin is affecting the skin prior to making treatment or for any individual patient. So the purpose of our program today is to identify treatment interventions that can help you prevent facility or home health acquired pressure injuries, and to prevent the recurrence of these pressure injuries after you work so hard and you close them. Sometimes you're getting these things closed and then they take the bed away from you, and 3 weeks later it reopens. You have to keep those beds, and we're going to talk about that. Long-term care, skilled nursing facility, long-term care. So a lot of skilled nursing facility. Thank you so much. CNA. Oh, I love our CNAs here. Is that not wonderful? CNAs. We're going to talk about our CNAs. And the other thing, oh, this is wonderful. So today we're going to focus on support services. You have a PowerPoint handout. You have these 8 different documents that Jacqueline's going to be getting to you. And the PowerPoint presentation is done in color, 2 slides per page. That's how I do this for you, in color, 2 slides per page when you get the PowerPoint. So you can take this information and go teach someone else this information. Each of you, if you get the opportunity, please become teachers. Oh, I'm going backwards. I'm so sorry. So these are your documents that I just talked to you about.
Pamela, real quick, it looks like we have one question from Ashlyn. Ashlyn, I'm going to let you come off of mute. Feel free to ask your question.
What do you got for us, Ashlyn? Ashlyn, can you unmute yourself?
Or perhaps it was a mistake.
Maybe. Okay. If you need to speak with us, put it in the chat or raise your hand and let Jacqueline know.
Perfect.
And that's for all of you. If you want to say something, if you want to contribute something, just either raise your hand or put it in the chat for us. So this is our program, the pressure injury prevention. When we look at the program, when you look at your program and how it's framed up, these are the things you need for prevention. You need leadership. And I see some people here that are on leadership, that are on this call today. And that's so important because it starts, whatever's going to happen. If you're the bedside LVN, LPN, you're the bedside, you're not going to make the difference overall for your building or your corporation unless the leadership is going to support you. Because coming from the bedside, there's a lot of great ideas, but we have to have leadership. It has to go up to leadership to get whatever we're thinking about or talking about to happen. So we have to have our leadership and the facility involved. If you're within a corporation, then we need the leadership in that corporation to be supportive of creating functional wound prevention and management programs. You want an organized, structured program framed on the current evidence-based and best practices and treatment guidelines and CMS regulations. CMS has great regulations. They're good regulations. Don't think they're stupid. They're not. They are wonderful. I've watched them grow up. I've watched the regulations for wound prevention and management of pressure injuries grow up from F314 that had 3 pages in the state operations manual, and now we have 20 pages in the state operations manual about wound prevention and management. And you're going to want that document, and it has been carved out for you out of the entire 900-page document. You have those 20 pages only, so you'll be able to look at that. You want to have facility protocols that describe the components of your pressure ulcer injury prevention program. Oh, and up here, number 3, This is where you have to look. You have to look at F686 if you're in long-term care, F684, F880. These are all long-term care. Section M has incredible education. If you're in home health, the OASIS has the exact same verbiage, except for a little bit of difference when you get to discharging people with wounds at the end for home health versus long-term care. But the language in the section M, and I saw an MDS coordinator. Thank you for being here. MDS coordinators love me because I teach you how to stage correctly when we get to staging. So your section M is important for you, has great education in it, and then your pressure ulcer injury critical element pathway. And we have an update for 2025, and I believe I gave you that update. I hope I did. If not, we'll get it to you. Also, when we're looking at our program, the facility protocol should describe the components of this pressure ulcer prevention program. And it needs to be comprehensive. Your protocols need to be comprehensive to educate new staff. How do you educate new staff, your new CNAs, your new LVNs, LPNs, your new RNs who are coming into your building on the regulations and current evidence-based wound prevention and management? There is no building you're going to go anywhere in this country. There's no care setting that you're going to go into that does not have chronic hard to heal wounds. It doesn't matter where you are. This is a specialty, and it requires a special, much deeper body of knowledge than we've ever had before. Like I said, I've been watching this for 40 years. We grew up from Whirlpool and physical therapists doing the debridement to where we have providers coming into your buildings. I was one of those physical therapists, and I have to tell you, I think it's fabulous when you have great providers coming into your building. I wish I had had that when I was in my buildings, had providers that would collaborate with me. So be sure you collaborate with your providers. So you want to have your consistent evidence-based education. This education has to be ongoing, and we get updates. I get updates all the time on current evidence-based wound management. It changes. What we did 10 years ago, we're not doing today. Wet to dry is out. Acetic acid out, which is vinegar and water. Dakins is out. Betadine is out. There are many, many things that are out, and we shouldn't be doing them anymore because they've developed the practice standards. So you want this consistent evidence-based education in your buildings ongoing for prevention of pressure injuries for all staff involved in care. And then you need to have the people that are going to do this thing that's wonderful and terrible at the same time, because it makes you really look at yourself. Self-evaluation isn't always the easiest thing to do, but it's your root cause analysis. If you get a facility-acquired pressure injury, you got to figure out where your system broke down, because it wasn't a single person that broke down. The system broke down. If you are getting facility-acquired pressure injuries, your system is not supporting you, not the people, the system. And then you need your quality assessment performance improvements process for facility-acquired pressure injuries to find the holes. Where are the holes in your program? So we have national guidelines and regulations, and we have a new update for 2025 on the pressure ulcer injury clinical practice guideline. And here is it. I just put this in the deck last night. It's the full body support surface for prevention of pressure injuries from the National Pressure Injury Advisory Panel, which is a component of the European Pressure Injury Advisory Panel and the Pan-Pacific Group. So these are three groups around the world that create this document that we call the National Pressure Injury Advisory Panel. That's the United States name. It's in Europe, it's in Japan, Australia, the Pan-Pacific Islands. So this is an international document, and it just came out with this support surface information that I'm going to give you today, and they have a brand new document. So you got that also. So one of the first steps in F686, the CMS, Centers for Medicaid and Medicare Services, SOM, state operations, sometimes you'll hear people just say SOM. It means state operations manual guidance to surveyors. Oh my, who are we guiding? Surveyors, but don't think it's just the surveyors. It's you. You want to read this document. Do not ignore this document at your risk, the people you lead's risk, your facility corporation's risk, both the facility and the corporation, and your patients and residents' risk if you ignore this document, the information I'm going to be giving you today. So F686, you want to read it, and it says one of the first steps is to identify that person that's at risk for developing that pressure ulcer injury, and then to implement the appropriate interventions. that are individualized to that particular person, and then monitor them. Monitor. This is where our systems are breaking down. One of the places, the monitoring, our CNAs need to be trained up to help the nurses recognize what's going on and to be detailed in their recognition. And we're going to talk about our CNAs because they're one of the most important people on the team. One of the most important people on the team. If you don't have savvy CNAs, your pressure injury prevention program is already broken from the get-go. So your 7 primary components of pressure injury prevention is your risk assessment and your monitoring. The risk assessment starts present on admission, what's going on admission, and then you're going to have your regular risk assessments after that. And you have your protocol in place for how to do that. The timing of it, we do it on admission. We do it when there's a change of condition. We do it quarterly when we do the MDS updates. So anytime you have a pathway for framing up how often you're going to do these assessments, and they need to be done regularly. You want to monitor our high-risk patients and residents more frequently than those that are more mobile and more ambulatory. Those that are chair-bound and bed-bound will need to be monitored more frequently than those that are ambulatory. You want to document your skin assessments thoroughly, and it starts present on admission. And be sure that your nurses, your LVNs, your LPNs, your RNs, if they're going to do the skin assessment, that they are trained and recognize how to do this thoroughly, and that they don't miss anything on admission that you're going to have to buy later, either with stars or money or any other corrective issues or situations that the surveyor puts on you. It starts with admission, and you want to be sure that your nurses that are doing the assessments on admission are good at what they are doing. You want to be sure when we look at pressure redistribution that we're using the support surfaces correctly. We're going to talk about that. Repositioning well and frequently. And the sicker these people are, the more you're going to have to reposition them if you're going to try to prevent pressure injuries. And then we have to have our devices for offloading, such as the heels. There's no reason to have heel pressure injuries. There's no reason to have heel pressure injuries. There's no reason to have heel pressure injuries. That is the easiest pressure injury to prevent, is on the heel. All we have to do is keep them floated. Now, I'm being facetious. It's not the easiest because it's sometimes very hard to keep our patients and residents' heel on the floating device, unless it's a boot or something like that. We'll talk about that later. Skin care, we have to keep the skin clean, dry, use pH balanced cleansers, ointments and creams, no lotions, ointments and creams, moisture barrier, skin checks daily or per shift. You may have to do a skin assessment per shift if this person is truly, truly compromised and they're in multi-organ failure. You may need to be looking at that skin every shift to see if it's changed, because when they go into multi-organ failure, the skin can disintegrate rapidly. You want your nutrition and hydration in place, and your dietitians are going to help you with this. And they need to understand, the dietitian needs to understand, and you need to understand that when we have a hole in the patient, we're losing a lot of protein. Everyone with open, hard to heal wounds is going to need extra protein almost. There's going to be, you have to have a good reason not to give them protein. When they are 75 years old and they are leaking a lot of exudate out of that wound, and that's leaking a lot of the protein that they need for wound healing. So most people are going to have extra protein on board for wound healing. And we don't put anyone on a diet. I don't care how obese they are. No one goes on a diet. You do not withhold calories or proteins, even from the obese, when they have large open wounds. That's not the time we worry about weight when we have open wounds. So balanced nutrition, vitamins if supplementation is needed, hydration. Older people don't even know they're thirsty. They've lost their thirst mechanism. And so you're going to have to remind them. Mobility, we could go on ad nauseum about mobility, but we need to do active range of motion, passive range of motion, therapeutic exercise per rehab. Get your rehab team involved in your wounds, particularly venous insufficiency and lymphedema. And there is money attached that the building or the rehab team will be able to garner that is appropriate for therapeutic exercise. You should be doing therapeutic exercise for these people with chronic wounds. You want to engage the residents in activities that engage mobility and repositioning, and then rehab is needed. And then rehab helps you with that exercise program that then goes to nursing, and we go into restorative nursing. All therapy can do is make a person as better to the point that they can, and then we go to a maintenance place. Physical therapy cannot stay in. Medicare does not let us stay in for maintenance. That's when it goes to nursing. So get your rehab to write, and it could be an OT also. OT may be involved in this. PT or OT, write the exercise prescription, and then it's handed off to nursing, and they monitor it. through the restorative program. Your supportive devices, your heel protectors, positioning devices, specialty beds, chairs support, all of these things, supportive devices need to be there. And then education and training. Do we educate the patients where we can, the families where we can, any of the caregivers about pressure injury prevention, and that's all of us. Train healthcare staff and pressure injury risk assessments and management. You need to have this ongoing training. It's never going to stop as long as you have new people coming into your building, particularly new nurses. This training is ongoing. So how are you going to set it up in your building that all of your new nurses get the training that you need for wound prevention and management, and all your new CNAs get the training that they need, and that the rest of the team is part of this wound management program, rehab, social services, dietitian, dietary. And then you want to encourage adherence to the repositioning and skincare practices. So when we think about the skin, and you'll see this several times as you go through this program, every single organ system feeds the skin. Every single organ system feeds the skin. If any of these other organ systems are out of whack, then the skin is going to begin to have challenges. And when these organ systems begin to go out of whack, they start crossing to each other. It's called talking to each other. It's called organ crosstalk. Oh, I'm not feeling good, the liver says, and the kidney says, oh, you don't feel good. I don't think I feel good either. And then the heart says, well, the two of y'all don't feel good, and I don't think I feel good either. And all this organ crosstalk takes place. So you want to know where these organs are, how they're functioning in this person. And I understand as a physical therapist. Why am I interested in the organs? Well, it's because it has to do with wound healing. If these organs aren't working, we're not going to get wound healing. So I need to understand the organs, not like an internist understands the organs, but I need to understand that these organs are in failure and that the skin is going to be affected as we go through multi-organ failure. And everyone that comes in your building is in organ failure, or they wouldn't be in your building. Okay, they came in for a joint replacement, so they're not in organ failure. Well, the musculoskeletal system failed if they needed joint replacement, but you're tried. Some of the other internal organs are in great shape, so this person may not have multi-organ failure. They're coming in for joint rehab, so that might be an exception to this multi-organ statement that I've just made. So did you pick up every ICD-10 code in the medical record? Are they all there? Are all the conditions recognized that's going to affect the skin? Are you sure that that wound is from pressure and that it's not a pressure injury imposter or a component of skin failure? As we go along this year, we're going to talk about this. So pressure injury prevention, 60 to 70% of that pressure injury prevention task falls under the scope of practice for your CNA. Are your CNAs up to speed so that they can help the nurses at the level that they need to and recognize what they need to recognize? So are they adequately trained to support your pressure injury prevention program? There are over 100 risk factors. We talked about this when we did the Braden program last month or the month before. It's not just 6 that Dr. Barbara Braden gave you. And you have to know how to do the Braden. If you've never seen the original Braden documents, I'm going to make every nurse on here mad at me, mad at this physical therapist. If you've never read Dr. Braden's original documents, if you've never had a mentor who taught from her original documents, you're not doing the Braden correctly. And those documents were given to you when we did the Braden and Beyond talk. So you really want to go back to those and take that information back to all of your nurses so that you can ensure that you're doing the Braden correctly. So possible causes for pressure injuries, pressure is certainly there. Shear is a big component. Immobility is the thing that tips the balance into pressure injury manifestations is immobility. Organ impairment or failure, this goes together. Why are the organs impaired? Which organs are impaired? Why is that person immobile? You need to know. Microclimate. Now, microclimate is your moisture plus your temperature, and this is the airflow that's near the skin. And we're going to go into microclimate in this talk. Decreased tissue tolerance that happens with the aging process. It also happens when we're dehydrated. It happens when we have anemia. There are all kinds of conditions that cause the skin to be less able to tolerate pressure. Then the body habitus, and that I want you to think about our skinny minis. Somebody that weighs 97 pounds and they're 5'2" and they're really, really skinny. Oh, well, they're not going to get a pressure injury because they're so skinny. No, they're the ones that are going to get it first because they don't have adipose tissue. They have skin and bone, skin and bone. So these are the people that are going to be at some of the highest risk for your pressure injuries are your very small, skinny people that do not have any adipose tissue. That has to do with the body habitus. Oh my. There we go. So the number one reason for acquiring a pressure injury is our immobility impairments. Everything else is a contributing factor. Now the body's set up for a pressure injury as the organs go into failure, and then you have a little bit of pressure or a lot of pressure. I don't know if you can even turn people fast enough sometimes when they're in multi-organ failure to prevent a pressure injury. And those become unavoidable pressure injuries. And you get that. Long-term care specifically gets the unavoidable pressure injury. Acute care does not. They were messed over on that one by CMS, unfortunately. And it is what it is. They'll have to handle that, and they're trying. People in acute care have been trying for 10 or 15 years to get that changed. So why are they immobile? We have to go back to why are they immobile? Tissue tolerance is important. This is looking at the skin and the supporting structures. When we have deep tissue ischemia, such as with pressure, we can have episodes of deep tissue pressure can occur without cutaneous manifestations, such as episodes that sensitize the skin. And what that means is we have pressure, the pressure comes off, and we have a reperfusion injury. Then we have pressure again, the pressure comes off, and it causes what's called a reperfusion injury. So subsequent episodes of lower amounts of pressure can result in skin breakdown from this reperfusion injury situation. Muscles, when you look at your muscles, they have the greatest demand for oxygen in the body. What is the heart? The heart is a muscle. You've heard the term angina. What does that mean? We don't have enough oxygen to the heart muscle. We've heard the term claudication. What does that mean? We don't have enough oxygen to the muscles of the calf. So oxygen, the muscles require the most oxygen to survive of any other tissue in the body. And so they have very little tolerance for these ischemic episodes when they've collapsed, when that person has hypotension, their blood pressure is low. Hypotension, you want to remember this. Hypotension is one of the number one reasons that people are getting pressure injuries when their blood pressure is going too low. And Dr. Braden, by the way, tells the nurses when they do their head to toe skin assessment, no matter what your number is, when you can add all 6 of the subscales up and you get that number, that risk score number, that total number. Barbara Braden said, if you have certain risk factors such as hypotension, a blood pressure less than 60 millimeters of mercury diastolic, or I have found the information where if it's less than 100 millimeters of mercury diastolic, and other hemodynamic instabilities, or that one or any other hemodynamic instabilities, decreased protein, fever, you're supposed to go to the next level of risk. So if you mark them as moderate from the 6 subscales that you added up, and they have any of these other comorbidities that Dr. Braden talked about, or any of these other 94 comorbidities, remember there's over 100 risk factors, you're supposed to go to the next level of risk. So we're not scoring our risk the way we're supposed to, and our EMR isn't helping us because whoever set up the EMR never read Dr. Braden's original documents. So your tissue tolerance, we have our intrinsic and extrinsic factors that are going to affect that person's tissue tolerance, which is the ability of both the skin and underlying tissues and supporting structures to endure pressure without adverse outcomes. And our extrinsic factors include moisture, wherever that moisture comes from. It can be sweat, it can be from the wound, it can be from an ostomy effluent, moisture, shear, friction, all of these are your extrinsic factors. And then your intrinsic could be nutrition, systemic oxygenation. What's the pulse ox? What's the pulse ox? Nurses, what's the pulse ox? If that person has a low pulse ox, they're going to be at higher risk for pressure injuries and lack of wound healing. What's their systemic oxygenation? And what's the local oxygenation? That's how much oxygen is in the leg. Do they have peripheral arterial disease? And ladies and gentlemen, if you're in long-term care, you suspect everybody of having peripheral arterial disease, everyone. And any wounds that are in the lower extremity, they always, particularly if they're full thickness wounds, arterial, venous, full thickness trauma wound, they hit their leg on the screw on the foot pedal, and they got a full thickness skin tear trauma. All of these lower extremity wounds are going to have blood flow studies, all of them. You cannot rely on your fingers to tell you what the pulse is, if you have enough blood pressure. Hypoperfusion, I've just talked to you about that. We believe this is the number one cause for pressure injuries, is hypoperfusion, including low blood pressure, and then other comorbidities. So your pressure ulcer injuries, according to CMS, a pressure injury has intact skin, which to the NPIP, everything is a pressure injury. The National Pressure Injury Advisory Panel says everything is a pressure injury. Europe is kind of like CMS. We have a pressure injury, that's intact skin. A pressure ulcer is an open ulcer with a wound. So that's how CMS looks at it. They don't care if you call it an injury. CMS doesn't care if you call it an injury or an ulcer. They really do not care. The result, the injury, is a result of intense and/or prolonged pressure or pressure in combination with shear. Shearing is the other culprit to creating our larger pressure injuries, particularly things like undermining. And I think I talked to you about that later. So the tolerance of soft tissue for pressure and shear may also be affected by skin temperature and moisture. So that skin temperature and moisture is what's called microclimate. And I'm going to be talking about our CNAs later, because it's not just repositioning that they're responsible for most of the time. As a physical therapist, I would reposition when I would take someone out, walk them, or work with them in the bed. Where did they start and where do I need to put them when I put them back to bed? So I would help with that. But for the most part, repositioning falls on the shoulders of our CNAs. And so I'm going to have something to say CNAs later. Be sure you get this back to them. So the tolerance of soft tissue for pressure and shear may also be affected by skin temperature and moisture, which is your microclimate, nutrition, perfusion to the area, comorbidities, and the condition of that soft tissue. So pressure, what it does is it causes the collapse of the arteries and the veins. You get this distortion and deformation of the soft tissue. Then the cells are damaged from the pressure. And we also, when we have this pressure, it's going to limit the nutrients and oxygen getting to that area. And it also eliminates that we can't get rid of the cellular byproducts. Those cells die and they deposit their little skeleton in that wounded area, and they cause inflammation. In a light-skinned individual, you can see that inflammation fairly easily. In a dark-skinned individual, we cannot. So, but you can see it, but you have to know what you're looking for and look at the different shades in dark skin. You can see it, but you have to know how to look at it. So this tissue that's compromised against that bony prominence creates a vertical shear, causing even more distortion. So tissue damage with high pressure applied for a short amount of time or low pressure for a long time can create pressure injuries. So possible solutions for pressure ulcer injuries: to limit that time of pressure duration. So that gets into your turning schedule, your repositioning schedule. Offloading the heels, and offloading means offloading. They're floating 100%. There's only air between that heel and that mattress, only air. And it doesn't matter if you're on a pressure distribution mattress or not. You still float the heels, even on a pressure redistribution mattress. You want to have appropriate repositioning for each resident. Micro shifts, asking that person when you're going past them in their wheelchair, can you shift it a little bit to the left, Ms. Gonzalez? Can you shift a little bit to the right? Do a little bit of shifting, and that offloads those ischial tuberosities, just a little bit of shifting. You can use dynamic support surfaces that actually, if that person cannot shift in bed or in the chair, there are support surfaces that will shift them, that they have bladders and they can actually move the person and shift them. Shearing is a big deal. Shearing is a big deal. So I don't know if you can see this the way I want you to. Goodness, I'm tearing up my office here. See if you can see this. All right, so this bottom has undermining from 10 o'clock to 2 o'clock. And you can see where my finger is going in here, about a third of my finger. So this is my undermining. Shearing is an evidence of undermining. We think this person is laying in the bed. When you bring the head of the bed up, oops, let me turn around this way. When we bring the head of the bed up, their skin slides down and they have this shearing, this torquing that goes between the soft layers of the skin. So CNAs, this is important. I know a CNA is on here. When you get ready to bring the head of the bed up, when somebody's, and they're going to slide down, if you will bend the knees first, if you ratchet the knees first, bend the knee area of the bed, bring it up, that kind of locks them in a little bit better so you don't get as much shearing. It decreases the shearing. So if you'll teach your CNAs, when they bring the head of the bed up, to ratchet that knee area first, you'll have less shearing of that skin. And this is just showing, this is, as you look at the top here, you can see my cursor, my little blue cursor, that's the occiput, and then the heels are down here. That's the heel. So this person is laying on their back. You're not seeing a lot of pressure or heat. 30 degrees, you're beginning to see that pressure. We're doing pressure mapping. You're seeing that pressure increase. 45 degrees, you can see the pressure going up higher and higher. 45 degrees, there's no pressure on the occiput, but look at all this down on the hips and on the medial side of each of the buttocks. So this is pressure mapping, and it's talking to you about keeping that head of the bed less than 30 degrees for the most part, but you're still getting some pressure. You can use trapeze if your patient or resident is strong enough, and I always get rehab to help set up the trapeze and to assess if that person is safe with the trapeze. Do they have the strength? Do they have the range of motion? Do they have the cognitive ability to keep themselves safe as they readjust themselves in the bed? Draw sheets, we're going to talk about draw sheets. We have to take them off. You have to take draw sheets off of your pressure redistribution mattresses. And I know our CNA is going to hate this. I know they're going to hate this, but they're going to understand in a few minutes. Slippery cover materials, we have more textiles, our sheets. Some of them have gotten more slippery so that you can actually move the person. The person can slide on it instead of having the friction that takes place. And the support surfaces that have these small individual cells, which we have some of that also. So some of the things when we have friction forces that we can think about, you want to remove the source of friction, such as pulling that resident up in bed or dragging the heels over the bed, over that bed surface. You want to use, if you can get them, if your building will buy them, the silk-like linens. The people move better in it. It's a newer technology for linens. Trapeze for those with upper body strength, and you want to ensure safety. And draw sheet can be used by the staff to reposition the person. However, you got to take the draw sheet out. I know, I hate it for you. I used draw sheets my whole career on moving people. But what we know now with the new technology that we have on the beds, we have to take the draw sheets off. That's all there is to it. So friction resists motion in a parallel. If you take your hands, rub them together really, really fast like this. I just saw a question over there. I'll come back to it later. And that's friction. So that's what you're seeing here. This was a friction injury. They have moisture-associated skin damage, and then on these sheets that they're on, they got their epidermis, the upper layer of the skin, rolled up. And this is the dermal layer that you're seeing. This is not granulation tissue. This is the dermal layer. Wound management is a visual discipline. You really need to know what it is you're looking at. And some of the things look very similar. Granulation tissue and dermal tissue look similar, but they're absolutely two different types of tissue. So when we look, you can see blisters sometimes when there's been friction in the area, abrasion and denuding. That's what you're seeing here. This is denuding. That's the term that you would use for this. So this epidermis is damaged, making the underlying tissue. Now we've lost that dermal layer, that top layer, the epidermis, and that top layer with the lipid on it, everything that helps prevent the bacteria that's sitting on our skin from making infections. Now this bottom is now at risk for bacteria accumulating on here and for making the situation worse. So we want to, when we have friction, often we have what's called superficial tissue damage, and that's what this is. This is a partial thickness wound. It has not gone all the way through the dermis into subcutaneous tissue, so this is a partial thickness wound. And friction is different from shear. This is what I wanted to show, and our CNA that's on here and any others that are here, I'm so grateful for you being here today, and nurses, please give them this information because it's so important for them to understand why they're doing what they're doing. One of the things the CNAs do for us is they reposition our patients. They go from the back, and then they go 30 degrees. It's 30 degrees CNAs, not it's 90 degrees side lying on that trochanter. You got to roll that person back a little bit so you're about 30 degrees, and you're on the fleshy part of the buttocks and not on the bony prominences. And when you do this, not only do you redistribute the pressure, but you cool the back. So repositioning. Note, increase in skin temperature is cooled rapidly with offloading. When you take that person from their back and roll them over, CNAs and nurses who are explaining this to the CNAs, you cool that skin. When the skin is moist and hot, the collagen is more fragile and puts that person at higher risk for skin injuries. So you want to, when you roll them over on the side and get them on the side, you cool off the back. And if you notice they're sweating, you might even want to fan the sheets to help cool them off and get that microclimate, that temperature and moisture. Lower the temperature, dry that moisture. Is going to make the skin stronger when you do that. So this speaks to the importance of repositioning, allowing the skin to cool, decreasing the skin heat and that moisture buildup. So repositioning addresses pressure, moisture, and heat. not just pressure, but all three of those. And what we're looking at here is where this microclimate is taking place between the bed, the surface of the bed, and the skin. So, and it might, and just like I said, it impacts tissue tolerance. It makes the skin more fragile when you have this heat buildup and this humidity. So we want to deal with this. We even have mattresses, low air loss mattresses do pressure distribution, and they also blow some cooling air to keep that person's to where they're not sweating so much. There is a problem with that if you have an open wound and you lose using a low air loss mattress, you can dry out that wound bed when you're using a low air loss mattress. So this, again, we're talking about tissue tolerance. And note, low air loss addresses the microclimate, and that microclimate is what you're seeing in red, where this person's skin is touching the surface of the bed. And then our moisture, that's our relative humidity. Again, moisture and skin temperature, increased skin temperature is your microclimate. When we have that increased humidity, it compromises, there it is, and it comes out of these guidelines. This isn't Pamela talking. Pamela gives guidelines. If it's something that's a clinical expert, clinical related to my clinical practice, I'll let you know. Otherwise, it's taken from all of the guidelines that we have. So increased humidity in skin also compromises that collagen bonds between the cells, reducing the skin's mechanical properties, which is your stretch and recoil, and reducing that resistance to tearing. So moisture and heat, we want to get rid of those. So moisture factors contributing are possible solutions. When we look at this, we want to reduce exposure to fluids, incontinence, and wound drainage. We want to keep that skin really, really clean. And our CNAs help with that. And by the way, I'm a PT that cleans poop. I want y'all to know, I will not let poop sit on the skin. And the reason is that poop has enzymes in it that are so detrimental to the skin. And here's the other thing, if you don't get all the poop off, that when that person, if they urinate, the feces is dry, say it's dry, there was a little bit was left behind because we didn't use a surfactant, which is a surface active agent. Our wipes have surface active agents. You can't just use water. You cannot just use water on feces. You have to have a surface active agent, which our wipes have that in them. If you don't use that and that person urinates on top of dried feces, it reactivates the enzymes. The urine reactivates the feces enzymes, and that is toxic to the skin and damages the skin. And you know what urine and feces does to the skin because you've seen it. You've seen that skin go that bright, bright, bright red, and that person is scratching and they're itching. So those chemicals from urine and feces is caustic, damaging to the skin, and we have to get all of it off. You want to use skin protectants. You want to ventilate the covers to help prevent that heat buildup. You want to do positioning and repositioning. You might need low air loss support surfaces. And if you can get them, those silk-like low friction linens. So this is an article has been provided that talks about support surfaces for the mobility impaired. We want full body support surfaces. Our specialized mattresses, overlays, or integrated systems that are designed to redistribute the pressure, reduce the friction and shear, and aid in microclimate management. All the factors that play a role in pressure injury development. So your pressure injury, your support surfaces, we want to look at how we're going to select it. So how do you select in your facilities? How do y'all choose which support surfaces you're going to use? And what we base that on is what's that person's level of risk that needs to be on the support surface? Do they already have any existing pressure injuries? What is their level of immobility? What's their comfort level, and how much, what would they need related to microclimate control? So when your pressure injuries fail to heal or they deteriorate, you might need to switch your support surface. The providers may need to reevaluate the entire medical situation. And that's not your job, nurses. That is your providers. Maybe it's going to be your medical director will help, or that person's, that patient or resident's primary care physician. Your wound providers, we're a provider group. Your wound providers can help you some, but they don't manage all the other conditions. They're not managing the heart failure. They're not managing the blood pressure. They are managing the wound. So you need your other professionals, medical professionals, to help manage the other comorbidities, and they need to be managed. If they're not, you're not going to get your outcomes that you want for wound prevention and management. So you might have to switch your support surface. If that person isn't improving, you might have to go to a higher level one. The providers need to reevaluate the whole medical conditions and then reevaluate the wound and the current wound treatment interventions to see if they're appropriate. Or has this person gone to the point where it's time for palliative wound care? And that does happen. There's times for palliative wound care. And oftentimes when people are on hospice, they're going to need palliative wound care. So we're not doing interventions to heal the wound. We're doing interventions to keep the person comfortable and to prevent the wound from deteriorating as much as we can. And then this person, they may have to go out, if they go to a higher level of multi-organ failure, then this needs to be documented, because this is why the wounds aren't healing. And when they go into the end of life, 10 to 14 days before people die, these wounds will usually begin to deteriorate. If they already have an open wound and they're going into the last couple of weeks of their life, the wounds will usually start deteriorating about 10 to 14 days before the person dies. So your support surface considerations for people with existing pressure injuries: if that patient cannot be positioned off that existing injury, then you're going to need a support surface for pressure redistribution. If they have 2 or more pressure injuries on 2 or more different turning surfaces, you're going to have a bed, a mattress, an overlay to help them. If you have pressure injuries, you only have 3 turning surfaces. Most of them aren't going to be on the 4th, which is prone, laying on your stomach. Most people aren't going to be laying on their stomach. So you have usually 3 turning surfaces. If you have 2 of them that are out, say on each side of the trochanter or on one trochanter and on the sacrum, you're going to have a support surface to help you. If that person is at high risk for getting more pressure injuries, or they've undergone a flap or graft surgery, they need to be on a pressure redistribution mattress. If the bed is totally uncomfortable, they might need to be on a pressure redistribution mattress, or if the bed bottoms out. So changing the support surface is oftentimes necessary. We have 3 types of support surfaces that have been recognized by CMS. We have Group 1, Group 2, and Group 3. Group 1 are your foams. They can either replace a standard mattress or be put on top of a hospital mattress if you want to. And they include mattresses such as you see here, pressure pads, mattress overlays, and they can be foam, air, water, gel. This is the lowest level of support surfaces that we have, called Group 1 support surfaces. Group 2 is what we see more often. Now, this is good for prevention. If you know somebody that's at a moderate risk for prevention, you might want to put this on the bed before they get a pressure injury. I suggest strongly that you do that. If you have people that are immobile, they're not very mobile, and they have organ failure and they have low blood pressure, I'd put them on here from the get-go. From the very beginning, you put them on something prophylactically. Yes, it might cost a little bit more money, but that pressure injury, if it's a facility acquired, is going to cost you a lot more. So you have to balance your resources. And resources include time of the CNA, time of the nurses. So we're not going to pay for this, but we're going to pay for all the time it's going to take for the pressure injury and taking care of it. We need to think smarter than that. Group 2 is what we see most often for people who have a pressure injury already. So these are designed to either replace a standard hospital or home mattress, or as an overlay. And it's powered air flotation, powered pressure reduction, air mattresses, and non-powered. So this is an alternating pressure, low air loss mattress, and you can see all the different channels that they can be inflated or deflated depending on what that person needs from an individualized perspective. We don't see this in post-acute care very often. We don't see Group 3 very often, because these are your fluidized beds where they have these silicone coated beads. They're in there and the person literally floats on it. Air is pumped in, and this is as if this person is on water. They're floating in these silicone coated microspheres. They look like white sand. And so this fluid state optimizes what's called immersion and envelopment. I'm getting ready to teach you about immersion and envelopment, because that is the technology of how your beds work. Immersion and envelopment. So we're going to look at that in just a minute. And it conforms to all the irregularities. But in general, we seldom see this in long-term care. Maybe if you have a vent unit, there may be some people that are on either the Dolphin or this other bed, Clinitron. Clinitron or the Dolphin, I think they have about 3 of them now. Clinitron and Dolphin, I think there's a 3rd one. So what do you need your beds to do? We want to do pressure redistribution. We want to alternate the pressure. Sometimes we need air to help because the people sweat so much. The technology, the way these beds work, is by immersion and envelopment. And then sometimes we have beds that literally do the lateral rotation. The CNA can't get there fast enough. These people are they are so hypoxic They have end-stage congestive heart failure, level 4 by the New York Heart Association, level 4 congestive heart failure. Their pulse ox is 85 at best on 6 liters of oxygen at the bedside. And if you don't turn them every 15 minutes, you're going to get a pressure injury. So we have beds that will do that, and they do a lateral rotation. Sometimes you cannot turn these people fast enough to prevent pressure injuries, and you need to recognize this. And your providers need to help you, nurses. Your providers need to help you. So this is the technology. If you lose this, you shouldn't even use the beds. If you don't use them correctly, don't spend the money for them, because you're still going to get pressure injuries on them if you don't use them correctly. So immersion and envelopment. And what happens, you see this person, they sink down. Immersion, the mattress cover material allows that body to sink down into that support surface. And what they're showing over here is every place on this leg and bottom and shoulder and the back of the head, showing you where it's gray, dark gray. That's where the mattress is touching that person's leg, their hip, their shoulder. Same here, thing over here. Look at this lady. The mattress is coming up between her legs. It's on the lateral, and every place that mattress touches these people, it takes some pressure off of the backside and redistributes the pressure to where it's being touched on the skin. So this person must sink in. Immersion. Do you think that's happening with all of your beds and all of your facilities, all of your patients and residents? Immersion, and then envelopment, that support surface envelops the body and at multiple locations, distributing that pressure over the larger areas of the soft tissue. So you have to be able to sink in. And that means that when you look at how full that bed is, I ask my providers, when you go to the different buildings, please press on that bed that they're laying on. And if your hand can't sink in with just moderate pressure, that bed is too full and you have to go talk to the nursing team. Immersion and envelopment. And then we're going to talk about decreased layers between the skin and the support surface next. But let's look at immersion and envelopment seating, because it's the same thing in seating. This person, here's their ischial tuberosities, just like you. If you happen to be sitting right now, I'm sitting on a ball. So, and my ischial tuberosities literally sink into the ball. So, and that looks like this. So this is immersion, where I'm sinking in, and then you get the envelopment, where this ball literally is coming up into my gluteal cleft and distributing this pressure evenly. I sit on this ball all day as I do webinars and do my work. So immersion and envelopment is also important for seating opportunities. Is that bed big enough for that person? Will it tolerate their weight? Does it give them the space they need? Is it long enough for them? So sometimes we have to have specialty beds depending on that person's body habitus, how they're built. And then we want to look at seating. This chair is for this short person, it's too high. They can't put their foot on the foot pedal nor on the floor. So they're loading their ischial tuberosities more. So the feet touch the foot pedal. This chair is too short. And when their legs don't come up to 90 degrees, and again, they're loading their ischial tuberosities. And this one's just right, 90 degrees at the hip, 90 degrees at the knees, 90 degrees at the ankle, 90, 90, 90. And if your people aren't sitting like this, maybe you need to be working with physical therapy. Now, I do have to say this about physical therapy. Your physical therapists need to know how to do seating. It's another level of training. They come out of school with some knowledge on this, and hopefully if they're in your buildings, they've gotten more knowledge to help you with your seating. You cannot do this, nurses, unless you've been in training, and the PTs can't do this unless they've been in training also. This is a specialty. Seating is a specialty, a high-level specialty with all kinds of seating surfaces, all kinds. And some of this very simple one right here, I actually have this one, and it works wonderfully for someone who has some minimal impairment in their seating and ability to change their seating, distribute their weight, their micro shifts. So rehab should help. You should have seating specialists if you need it. And every company that sells these things, they all have seating specialists. So if your therapist won't help you, the companies that sell the support surfaces will be able to help you. They all have probably certified seating specialists. So when we look at seating, what are we going to do? An air cell, a foam, a gel, air columns. There's all different types with a pump or not with a pump. There's many, many, many. So you want to consider an alternating pressure air cushion for individuals who are in a chair for prolonged periods and they can't do some of those micro shifts. Then they're going to need a special, if they're going to sit, they're going to need a special type of seating device. Bariatric chair cushions need to be based on that patient's size and their weight. So I also gave you this article provided. This is your wheelchair seating pocket guide that gives you some ideas. Do they need to have a seating specialist? And so this is yes, no, yes, no, yes, no. Do they have these situations going on? And if they do, nurses, you use this to determine, do they need a seating specialist? You don't just say, oh, we don't have seating specialists. You figure out if they need a seating specialist, and then you call the companies. You can find these people that can help you. And so if you answer yes to any of these risk factors listed, take action, refer to therapy for seating evaluation, or prescribe a skin protection support surface, whatever it may be. So this is something that has also been provided for you today. Our dressings to prevent pressure ulcers. We do have some research that shows that a 5-layer dressing in ICU, that's where this study was done, a 5-layer dressing decreases deep tissue pressure injuries specifically, but pressure injuries in people who are immobile. So this is people that were intubated and they were in multi-organ failure and they were in the ICU. And this someone that I know actually did his PhD dissertation on this. And sure enough, they found that using a foam, 5-layer foam, prophylactically decreased the number of pressure injuries that they got in the facility, in the hospital, in the ICU unit. So studies show that appropriate dressings applied to the heel. Now we have them also you can put them on the heel also, help reduce 2 contributory factors for getting a pressure injury, shear and friction through these multiple layers. And they also influence microclimate because it wicks away the moisture from under the skin. So this is the bottom of the dressing. This is the top of the dressing. You can see my little cursor here. So the moisture, that person sweats, and they're on our beds are all covered in plastic. And that's when they sweat, they absorb that moisture. Remember microclimate, moisture and heat, wick that microclimate away. That's one thing that happens. So it helps to influence the microclimate. And research has shown that using prophylactic dressings along with heel offloading resulted in fewer pressure injuries than without using the dressings. Foams do not offload direct pressure forces. It's not a replacement for floating the heels. Absolutely not a replacement. It's not a replacement for turning and repositioning unless you cannot. When people are intubated, sometimes it's hard. You can turn them, but sometimes it's more difficult and you have to be very careful. So CMS does not reimburse for prophylactic use of foam dressings for pressure injury prevention, but you might want to do it. If you have a high-risk patient and you're doing everything you can to prevent a preventable pressure injury, you might want to consider using foams. So what do? They manage your moisture, they help with temperature regulation, and they help decrease friction and shear. Offloading the heels, very, very important. This was present on admission, and all I can say is these buildings in Arizona that said they aren't going to do the head to toe skin assessment because they don't think they have to. They're going to be in real trouble when this kind of stuff comes in, and they didn't do that head to toe skin assessment on admission. I don't even know where their heads are. I really don't know where their heads are. So heel pressure injuries, these are heels that were not floated on an immobile patient. You want to float all heels on an immobile patient. It's the most preventable of all of the pressure injuries. So pillows, if you're going to do your pillows like this, I don't like pillows because I can't keep pillows even for myself. I'm not able to keep a pillow under my legs. I've tried it to see how it works. It doesn't work for me. I wiggle too much. So you can tell this heel is floating just a teeny tiny bit. And you also want the knees bent a little bit. My CNA that's on here, if I have more CNAs, yes, thank you for being here. You want those knees bent just a little bit. And the reason for that is it's believed to help prevent DVTs, deep vein thrombosis behind the knee when the people are in bed a lot. So this is how, if you're going to use pillows, this is how you're going to use it. But there are other things to consider. So you want, this is, when we use a pillow, this is showing a pillow under the Achilles tendon. You get hyperextension of the knee, and that is believed to create an issue for potential deep vein thrombosis. So you don't want to do this. You don't want to hyperextend the knee. That is important. And so your 30-degree lateral positioning, you can try pillows. They don't work very well. These are going to help better. I love this one because you can break this apart when you have that sacrum. You're able to offload the sacrum completely. So this is looking at your 30-degree turning, which is how we want to turn our people when we're doing their rotation left and their rotation right. Then the Fowler's position, again, if you'll ratchet the knee first, then that person will not slide down as much, and you'll be preventing some of the shearing that takes place. And you want the low Fowler is that 15 to 30 degrees. You want to use a board or foam wedge under the plantar surface of the feet to stabilize them if you have to. So the sacrum is highly loaded in this position, and if this person is immobile and frail, they're going to be at high risk for pressure injury. Linens and layers, one of the things that's important for you to understand is the technology on your beds. The technology on the bed, what is covering that bed breathes. It's not like our mattresses that don't breathe with that plastic. And it has stretch and recoil technology. So the stretch technology, it stretches 4 ways. This mattress cover on these beds, it stretches this way, it stretches this way, and that allows for the immersion and envelopment, which is why we don't put chucks or other linens or draw sheets or even briefs on our patients and residents that we're trying to heal these wounds, because we need them to sink in with the immersion and then have that envelopment and these layers, these materials, the sheets, chucks, diapers between the person and the support surface. You lose your immersion and envelopment. You lose this 4-way stretch technology so this person can sink in. Sheets create an additional layer that can reduce the amount of immersion a person experiences. Most sheets do not have this stretch recoil technology, and it's going to limit the ability of that person to sink into that bed for the support surface to contour to that person's body. Draw sheets. So sometimes we'll have a sheet under there. Then we have a draw sheet. So draw sheets are often used, and the draw sheets are usually doubled. Draw sheets are often used to reposition the individual. If left on that support surface, it reduces the surface's effectiveness by not allowing that person to sink in for the immersion and the envelopment. So what does this mean? I hate to say this. I hate to say the CNAs, but I have to say it. We have to take the draw sheets out from under our patients and residents. We have to take the draw sheets out if we're going to use a bed that has the technology of immersion and envelopment. Standard sheets and draw sheets may trap heat. That's the other thing. And moisture, microclimate. That's heat and moisture, microclimate, affecting that skin integrity, again, causing the skin temperature to increase, what makes it more vulnerable. So chucks pads are usually made from materials designed to prevent moisture to leak through. And when we use these pads, we lose immersion. The plastic absorbent material in that chucks can create pressure points. You know how they get wrinkled under there, and uneven distribution of the pressure, interfering with how that support surface is working. We lose immersion. They're not breathable. They create a heat buildup. And so we have this heat and moisture accumulation that makes the skin more detrimental. Our bright diapers and briefs, they add padding. They can reduce the direct contact between the skin and that support surface, again, reducing the immersion. The bulk of the diapers and briefs create pockets of uneven distribution, which affects the surface's ability to distribute that pressure evenly. And we get this moisture accumulation. They're designed to trap moisture that can lead to higher skin temperature and moisture or microclimate, increasing the skin's breakdown. So this is showing the effect of multiple layers. So this is a low air loss with one fitted sheet. Not too bad. Not too bad, particularly if those fitted sheets are loose. If they're loose, they're going to be able to immerse a little bit. This is a low air loss with a fitted sheet and an underpad and a chucks. Well, I thought the underpad and the chucks were the same thing, but what do I know? So you're showing that you're having more heat and more pressure buildup. Now, I can't even tell you why. They have 9 layers over here, but they have 9 layers, and you can see all of the heat and pressure buildup. So it's going to be, again, this is looking at the low air loss mattress and putting sheets on top of it. So we want to take this in consideration. So you want to know your technology. Someone needs to have the knowledge of how the equipment works, check on the support surface to ensure they're appropriately set to allow for immersion and envelopment. Oftentimes our providers will go into the buildings and the beds the pump is not set where it needs to be. It's full. The bed is full. For whatever reason, the bed is full. And we need to let the air out so this person can sink in. Let some of the air out. So support surface decision making and F686, there's a huge section on prevention and treatment strategies. And it talks about redistributing pressure as some of your interventions, minimizing exposure to moisture and keeping the skin clean is mentioned, providing appropriate pressure distribution, your support surfaces mentioned, non-irritating surfaces. We want to improve nutrition and hydration. This is our treatment interventions that's mentioned. Every bit of this is listed in F686. You want to know F686 backwards and forwards, and particularly if you're the clinical lead, you have to know your entire state operations manual, almost 1,000 pages. It is what it is. Adverse drug reactions can cause a problem, and the interventions need to be incorporated into your care plan. And what do the regulations talk about? The regulations talk about a static reactive pressure redistribution in F686. The use of support surfaces does not eliminate the need for repositioning and skin assessment. Now, CMS is saying that, but all the literature tells you the same thing. Just because you have a support surface does not mean you stop turning and repositioning and offloading those heels. You keep doing all of that. That pressure redistribution surface is for that person that cannot turn the way they need to. They cannot turn on a regular bed, but you still need to do turning and repositioning. Remember, because of multi-organ failure, their skin is so fragile that they cannot take the pressure that you and I can take, or that other patients and residents who are still mobile can take. There's dynamic active pressure redistribution, and may be indicated when the resident cannot assume a variety of positions without bearing weight on an existing pressure ulcer or pressure ulcer injury. The resident completely compresses, or the resident completely compresses a properly functioning static device. So you may have to go into a dynamic device where that mattress is turning itself. When we look at the frequency, we need to account for the support surface and optimal repositioning, what type of surface is being used, what's the goal of that category. And in F686, it tells us that we have to look at that person's level of activity and mobility. We have to look at their general medical conditions. We have to look at the overall treatment objectives, their skin condition, and comfort. For residents dependent, look at this. For residents dependent on staff for repositioning, the plan of care may indicate repositioning at least every 2 hours or more frequently, depending on the resident's condition and specific needs. There are people that are so frail in our buildings that 2 hours is not enough. Now, once you start getting down to an hour or every 30 minutes, you probably need a bed to do that for you. So you might want to go back, think about the residents you have in your buildings right now. And if you can't get that bed, then you're probably going to end up with unavoidable pressure injuries. And I hope you know when to call it unavoidable. So what does the evidence say? It says to select a support surfaces that meets the individual's pressure redistribution needs based on their level of immobility and inactivity. And that support surface should not further impair their activity or their immobility. The need to impact microclimate and shear needs to be taken into consideration. That person's size, their weight. You do not put a skinny mini 98, 105-pound person on a bed that was meant for someone 400 pounds. You do not do that. And we had that done recently. They didn't have the bed, so they put the person on the bed for 400 pounds, and they got a pressure injury because the mattress for 400 pounds is very different technology than the mattress for somebody that's a normal average weight. So the number and severity and the location of existing pressure injuries may determine what type of bed you're going to need. If we have 3 pressure injuries on 3 turning surfaces, you're going to need a bed that's going to turn this person every few minutes to try to give each pressure injury an opportunity to have blood flow. If that person is at high risk for developing new pressure injuries. And the other thing I want to say is that you need to keep the beds for a while. When that full thickness wound closes, that's a partial, becomes a, it's still in the maturation phase of wound healing. It's still in the maturation phase. And that wound often breaks open after 2 weeks when that mattress is taken away. So try to keep those mattresses for at least 3 months. So your key takeaways: no single support surface is optimal for all patients, but a minimum A single layer high specification foam is recommended. Individualized risk factors and patient comorbidities must be considered. The use of a support service, no matter what kind, does not eliminate the need for regular repositioning. Addressing a patient's mobility issues may be one of the most important interventions for reducing the risk of pressure injuries. So in summary, you do your skin assessment and you capture all of the skin issues. Your risk assessment, you want to capture all the potential and current comorbidities or conditions or risk factors that can lead to a pressure ulcer injury. Care plan for each and every risk factor. You cannot call something an unavoidable pressure injury, which CMS gives you, and that's going to be a talk coming up. The unavoidable pressure injury, you can't call it unavoidable unless you have care planned and monitored the care plan for every pressure ulcer risk factor. And the surveyor can see where you've done your interventions consistently, implementing that care plan for turning and repositioning, monitoring the prevention outcomes daily for at-risk individuals, modify the prevention interventions necessary to prevent the facility-acquired avoidable pressure ulcer injuries. And if you get an avoidable facility-acquired pressure ulcer injury, was it really avoidable? Your root cause analysis is going to tell you that, if it's avoidable, or unavoidable. And modify your pressure ulcer injury prevention protocols based on your quality assessment and performance improvement. What are the holes we found in our pressure injury prevention program when we did our QAPI for this patient? So we're done for now, and let's see, do we have some questions? Because I know that I'm running a little bit late today, and I apologize for that. I don't know how that happened.
No, that's
So,
okay. We have a bunch of questions, Pamela. I decided to just save them for the end because we had
okay,
so many good ones. So I'm going to start at the top here, chat.
good, good. Now, if y'all have to go, we understand it, but if we're going to go through your
Totally.
questions, if you can stay.
Totally. Yep. And then don't forget, it's still being recorded, so you'll get this portion. This portion will be saved in the recording as well.
Okay. So what
Okay,
you got, Miss
Chad
Jacqueline?
asks, what can be used to replace Dakins?
What can be used to replace Dakin? So Dakin solution is bleach and water. There are all kinds of products out there. One of my favorites to replace Dakins, because we're looking at antimicrobial effects, is Vash, VASHE. I don't have my Vash here. Vash is something that we use in wound care a lot. It can replace Dakins. It is a hyperchlorite. It's not bleach. It smells like bleach, but it's not bleach. It's not cytotoxic. So that's one of the best. VASHE. I get it every month off of Amazon because we use it in our home extensively. And you can even put it in mucous membranes. That's using it off label. It's for wound care primarily, but I put it in my eye when I had a sty and I couldn't get rid of it with Puricin. So Vash, VASHE. Now, Dakin solution, if you have an infected wound on a person that is on palliative care or hospice, and you have an infected wound, you can use Dakins for a few days. Even if they're not on palliative care, you can do Dakins for 3 to 5 days, but you're not going to use it continuously because it damages the cells that you need for wound healing. But if they're on hospice, you have a really stinky wound, you can use Dakins till the end because you're not trying to heal the wound. Okay, what else? That was a good question.
Perfect. Michelle asks, do you have the Braden docs for those that couldn't attend that in service? Michelle,
I
I can
do.
answer that. I was gonna say I can get those to you, Michelle. Let me make a quick note of your name and I'll send them to you by email.
And
Okay.
does anybody else want the Braden documents? If you do, is there any way that you can plop them in here? Just, do you know where they are?
Um, I do know where they are, but just for the sake of time, it'll be faster if I email it. So if y'all will just put your
Okay,
name in the
okay.
chat if
And
you
so
want the Braden documents, I'll
yeah,
email it
put
to
your
you.
name in the chat and she'll get the documents to you because they really are important. And I just
Perfect.
saw somebody had their hand up, but now I don't see them.
Oh, I think they're putting their hands up for the
Oh, for the
document, it
Braden
looks
document.
like.
Okay.
If
All right. So
you'll
you'll just
type
send
your
that
name
to
in
me.
the chat, that way I can keep track of it a little bit easier for everybody.
Okay. Yes, everybody
Um,
wants them. Okay, good.
Awesome. Okay, Lindsay Logan asks, do we go down a risk level for each comorbidity that they have?
Say that again, please, Jacqueline.
Do we go down a risk level for each comorbidity that they have?
Not for each one. Say that you have 2 or 3 comorbidities, you just go one level up, whatever it is. You'll say they have you have a low risk level. You got a good low Braden score, so they're at risk when you did the 6 Bradens. And then they have 2 or 3 or 4 other issues, like they have congestive heart failure with a pulse ox of 84. They have a fever. They're running a fever. You don't go up a risk level for everything. You just go up one risk level. So they go from minimal risk to moderate risk when you have more risk levels, or they go from moderate risk to high risk, and you don't take the risk away. Once they're at moderate or high risk, they're always at moderate or high risk.
Gotcha. Judy asks, does this indicate incontinent pads as well if they are cloth? I think that might have been a
This is including continent pads if they're cloth. Well, like the pad, it's not going to have the plastic, and I've not seen the incontinent pads that don't have a plastic, but like Chuck's, I've not seen that. But those incontinent pads absorb. Um, it's going to be anything that messes with the stretch technology. That 4-way stretch, anything you put under that person that does not allow that 4-way stretch on your bed is going to take away how that bed works. You lose your technology. Whatever you put under that person, you lose the technology. Yeah. Unless it stretches. God, we need to, hey, okay, y'all, we need to create that. We need to create something that stretches 4-ways technology and absorbs. You'll be
Yeah.
multi-billionaire if you figure that one out. What else have we
Yeah,
got,
exactly. Use our
Jacqueline?
powers for good. Okay, Chad asks, we were taught to never use sheets on low air loss mattresses. Has this changed? Can we use fitted sheets?
Nope, it hadn't changed. Not let those sheets have 4-way technology, and they don't at this point. So I was taught the same thing, and that's the reason. It's because of the technology. We lose it when we put those sheets on.
Gotcha. How often should you be changing those prophylactic dressings on the heel sacrum?
I think you can leave them on for about a week.
Okay.
Oh, if the patient complains of pain and they have that prophylactic dressing on, I would take it off and check the skin. If they're checking, if they say, "Oh, I'm having some discomfort under this," I would check it. But my understanding is that you can, it's as long as they are okay, they're not complaining. Now, some of the people, I shouldn't be saying this because some of the people are in the ICU, they weren't able to say anything. At least weekly, maybe more often, if you think that there's something going on under there.
Mm,
I would say
mm.
that. And I'm going to check on that. Um, what else we got, Jacqueline?
Yes, Patricia asks, for those residents who are incontinent, how do we manage incontinence without a brief on air mattresses?
I don't know. You know, I don't know what the intervention's going to be. You're asking what we can do to keep the incontinence contained without losing immersion and envelopment. At this point, I don't know the answer to that.
Okay.
So if you feel like you have to use the brief, then you have to use the brief, recognizing that you're going to lose some of your immersion and envelopment, and how are you going to address that? That's all
Gotcha.
I know to say, to be honest with you. We don't have, unfortunately, briefs right now that have 4-way stretch. I'm
Mm,
thinking about it though.
yeah, I love that. Judy asks, can you provide any care planning examples to help with keeping up to date with guidelines and risk factors?
Care planning, care planning references.
Care planning examples, she says, to keep up to date with guidelines and risk factors.
One of the ones that I recommend that you look at, care planning guides. For instance, in the Braden documents, Dr. Braden gave you in the Braden document some of the things that you could do if that person is at risk, for some of the things that you can care plan. So some of the things you're going to care plan: turning and repositioning, moisture control, nutrition, activity. These are the things that you care plan, the things that are on the Braden. Now, loss of sensation. I don't see our nurses doing monofilament testing. for people with diabetes, but loss of sensation, the only thing you're going to care plan for, take your 6 categories and you care plan for all of these. Now, some things you can't care plan for. For instance, somebody with congestive heart failure, which is a big, big risk factor for pressure injuries, you have to hope that congestive heart failure is being care planned by the cardiologist or the primary care physician. So the nursing side, you're going to be care planning for the things primarily that you see in the Braden document. That's what you're going to care plan for. And I think y'all have that down pretty well. The medical management part, that goes back to your providers, and hopefully they're helping you. You are only going to be able to prevent these pressure injuries at the level that the providers help that person stay as healthy as possible, or even heal them. That person needs to have some health to be able to heal those pressure injuries. And that's on the providers looking at the organs. You're not responsible for that, but you are responsible, nurses, for what's happening at the skin level.
Mm. Patricia asks, for larger residents, how do you turn them without a turning sheet, especially if they are not able to help?
All right. When you have somebody, this is my person right here. Here's my person. So what I'd have to do, say they're on their back, and we can turn them one side, and then I have to take out the sheet underneath them. So I roll that sheet up, put them on their back, tilt them a little bit this way, and pull it out the other side. It's hard. It's not this not easy. But when you have that sheet under them, you turn as far as you can to one side, you push that sheet up under them, and then you take them the other side and you pull it out. When it's time to put it back under, same thing. I'm going to tilt them. I'm going to shove it under as far as I can, and then I'm going to take them to the other side and roll them a little bit, and then I'm going to be able to move them up, down, side, side. But it's not going to be easy. It's a rolling thing that you have to do. It's a manual thing that you have to do, unless you have one of those beds that does that tilting. And we don't have a whole lot of those. Those are more expensive. But you'll have to push that draw sheet under there, and then put that person back, and then come the other way and pull it out of there. And it's a pain in the derriere for you. I get that. All this stuff is a pain in the derriere for you. I get that. Anything else?
Alrighty, that is the end of our questions here. I've got everybody else's names and information, so I will send the Braden docs to you all. I'll also just go ahead and include it in the follow-up email as well, because there's probably 30 plus people here that want the Braden documents, which is awesome. So we're happy
That's
to.
great. That's
And
wonderful.
Chad, Pamela did answer the Dakin's question just a few minutes ago. Pamela, will you just summarize that really quickly?
Okay, when we use Dakins, you can use Dakins, which is bleach and water, for short periods of time, 3 to 5 days. If you're looking at wound healing, you can use it much longer than that. Say you have somebody with cancer and their wounds stink, and you're using Dakins to help keep the bioburden under control. You can use the Dakins until they pass, because wound healing isn't your goal. If wound healing is your goal, you stop using Dakins after 3 to 5 days, and you can go to something else, such as Vashe. It's spelled Vashe. Vashe. And I highly recommend that you get this product for all of your wounds in your buildings. It is a fabulous antimicrobial product that's not super expensive. It's more expensive than Dakins, but using Vashe is less expensive than having an infection in your building. Just saying. Yeah, Vashe. It's right now, it's one of our favorite, not just me. Everybody in this industry is using Vashe to help decrease our bioburden, decrease the inflammation. It helps with bacteria. It helps with fungus. It helps with inflammation. Vashe is a wonderful product to use in wounds to help control your bioburden, and you don't have the cytotoxicity that you get from Dakins. Yeah. Vashe. Yeah. Oh, that's okay. No worries.
Perfect. Well, I think that's
That's it,
everything.
Miss Jacqueline. Thank y'all for staying. You were a great group, so interactive. This was fabulous. Thank you. We'll see you next month. Jacqueline's already put this up for you, staging pressure ulcer injuries and coding tips. I hope we have more MDS coordinators. See if you can get your MDS coordinators here, and we will see you next month. And Jacqueline, you won't be here next month, will you?
I will not. I will not. There will be another visitor from United Wound Healing in my presence for next month. So I will see y'all back here actually in January. So
In
we'll have two more
January.
sessions this year, October, November. We'll skip December. We'll come back in January. So more to come there, but we will see you all soon.
Take care, everyone. Thank you for being here. Bye bye.
Bye-bye.